I'm pleased to introduce the first WPA's webinar on telepsychiatry, which aims to provide you with the basics of using video conferencing in the field of remote mental health care provision. We have known telepsychiatry for over 60 years, but the regulatory constraints in combination with clinicians' concerns have kept telepsychiatry from being widely adopted. Accordingly, the pandemic period for the vast majority of clinicians worldwide is the first time they use telepsychiatry, and very few have received training in how to do it. This is one of the reasons why we within WPA have worked to develop telepsychiatry global guidelines, along with preparation of this webinar, as well as other symposia and activities related to WPA conferences in the future, all of which aim to enable specific knowledge and competency training for current and future providers of mental health care. But let's start with the definition of telepsychiatry. The term covers the use of video conferencing in mental health care provision on distance. It's mostly interactive, synchronous video conferencing in real time. The so-called store and forward model, which is asynchronous telepsychiatry, can be used in situations where synchronous approach is not possible. In such situations, the physician, typically general practitioner, conducts an interview with the patient, records it and sends it to a psychiatrist for evaluation, diagnosis and treatment suggestions. This approach can also be used for educational purposes, typically remote supervision. Now, let's look at the evolution of telepsychiatry. Historically, access concerns have driven much of the work of developing clinical telepsychiatry. In April 1924, an imaginative cover for the journal Radio News preceded telemedicine in its depiction of a radio doctor connected to a patient not only by sound but also by live image. The story of telepsychiatry started back in 1955 in circuit TV system at the Psychiatric Institute was used for the direct transmission of therapy sessions to students at the medical college for educational purposes. The scientific articles back in the early 60s described the use of technology for teaching psychiatry. In 1968, Dartmouth's Department of Psychiatry in the state of New Hampshire was connected to a rural affiliate hospital, resulting in a direct remote patient consultation. In addition, the technology interface allowed for clinicians to operate the equipment themselves. In 1973, Massachusetts General Hospital psychiatrists used TV technology to see patients at a nearby airport. This project was noteworthy for the first use of the term telepsychiatry. and the use of remote-controlled cameras to pan, tilt and zoom, enabling remote body language reading. The pioneer efforts within telepsychiatry development were made in the United States. In the late 80s, telepsychiatry was launched in Canada and Australia to serve primarily underpopulated, underserved rural areas. European experiences go back to the 90s, primarily in Scandinavia, Norway, Sweden, Finland, where large geographical distances make it difficult to get to the doctor. Everywhere we used standardized and expensive standalone video equipment. But within the last decade, we started developing video platforms that operate on personal computers and mobile devices. Telepsychiatry is rapidly growing and constantly changing. So it is important to know when each of telepsychiatry applications was launched and described back in time. Brief outline of oldest and most important references may give you an idea of how long time we have been researching telepsychiatry practiced by standardized standalone video equipment within a variety of settings, patient populations and mental health conditions. In 1996, telepsychiatry in primary care was proposed as a means of improving communication between primary and secondary care. Harrison and allies have highlighted the advantages of a joint consultation model, in which the general practitioner participates in the patient's consultation at one side with the remote psychiatrist located far away. Such approach does not increase the burden of providers, but does increase the competencies of general practitioners due to regular remote supervision. The project that I launched in Denmark back in 2010 connected my clinic, the Little Prince in Copenhagen, with general practices in outskirts areas of Denmark. It was amazing to see how excited and satisfied the general practitioners were by getting the possibility to improve their competencies due to regular supervision and involvement in diagnostic and treatment course of their patients. Patients, on the other hand, were happy to get relevant treatment in the privacy of general practice, which they were used to visit for years. Many patients mentioned advantages related to no need for travel and diminished stigmatization. The pioneer telepsychiatry service in psychiatric emergency room describes follow-up consultations with 60 patients in Finland back in 2005. Overall, high satisfaction and reliability was reported. The first descriptions of various telepsychiatry applications for children and adolescents date back to the end of the 20th century, describing both the assessment and treatment of children and adolescents with variety of mental disorders. The American Veterans Health Administration invested time and resources in education and clinical guidelines, particularly related to telepsychiatry-provided treatment for PTSD. Interesting surveys are dealing with veterans' re-entry into regular life, whose fear of stigma reduces help seeking and who prefer technology-based platforms. It seems that PTSD veterans respond better to remote approaches than to personal treatments. It may be due to stigma. Former soldiers, heroes on the battlefields may feel useless in a time of peace, burdened by PTSD symptomatology, but ashamed to be seen in psychiatric clinics. In such situations, telepsychiatry proved to be preferable to traditional in-person approaches. Telepsychiatry saves time and money on the high seas, which is why American military choose it for provision of real-time consultations on distance. Telepsychiatry in assessment and treatment of deaf and hard of hearing individuals is feasible and efficient. As early as 1997, the use of video phone for psychoanalysis of 2 patients have been described. 1 year later, CBT and psychotherapy supervision were delivered via video link. We know today that online cognitive behavioral therapy shows evidence of efficacy, but often lacks effectiveness in real-world settings when provided without human support and interaction. That so much needed interaction can be delivered through telepsychiatry, not only within CBT. Most applications within e-mental health can become more accessible to its users through telepsychiatry once we learn how to use the technology. At the beginning of this century, more remote psychotherapy was described as reliable and comparable to in-person therapy. The provision of psychological services via video conference is called telepsychology and has been described and documented last 20 years. Supervision and psychoeducation of those who work with mentally ill individuals at remote locations by use of video conference in real time has been described in several articles ever since 1998. Telenursing has been described since 2002, related to both clinical work and remote supervision. Telepsychiatry is particularly interesting in psychogeriatric services, parallel with development of so-called telepsychometry, a remote psychometry consultation in clinical gerontology, invented in 1996. Remote services to elderly homes or to patients in their own homes have been described 20 years ago. Telepsychiatry in forensic settings like prisons and correctional institutions is highly appreciated and useful, especially for remote evaluations of involuntary treatments of prisoners. Current pandemic made inmates especially vulnerable as social distancing is not easy to maintain in overcrowded prisons. Along with COVID-19, the inmates have to deal with mental health consequences of the pandemic as well. Benefits of telepsychiatry in disaster scenarios has also been documented and is notably applicable in the context of the inevitable psychological sequelae it results in. However, its use has previously only been considered when dealing with a relatively localized disaster. The widespread nature of the current COVID-19 emergency is unique and justifies global use of telepsychiatry services, as well as increased international collaboration that unfortunately is limited due to regulatory constraints. Back in 2000 in Denmark, I launched the first transcultural telepsychiatry service in Europe. It was Danish pioneer telepsychiatry project aimed to assess and treat refugees and migrants by bilingual clinicians through telepsychiatry, without use of interpreters. As we all know, mental health systems worldwide are not tailored to the needs of minorities. Therefore, ethnic minorities are usually assessed and treated through interpreters. My idea was to try telepsychiatry via bilingual clinicians who speak the languages of the patients so that the use of interpreters could be eliminated. Transcultural telepsychiatry model showed to have a very positive effect on patient satisfaction, primarily because of no need for interpreters, easy communication with bilingual clinicians, no risk of misinterpretations and misunderstandings that could otherwise lead to misdiagnosis and consequently to non-optimal treatment suggestions. Furthermore, interpreters provided communication is more time-consuming for both doctors and patients. And finally, more expensive due to interpreter fees. The transcultural telepsychiatry model has also been described later related to assessment and treatment of Hispanics, Latinos, Asians, and Native Americans. The idea of using bilingual clinicians in Denmark was not easy to implement. At that time, we only had a few psychiatrists who were bilingual. Therefore, I invited my colleagues speaking Arabic, Turkish, Kurdish, Polish from Sweden. It was the first time ever that clinicians from abroad assessed and treated patients in Denmark through video conferencing in real time. The first international service, launched back in 2006, is still the only such service in the world. The international transcultural telepsychiatry model can be particularly useful in the current refugee crisis in the European Union, as well as anywhere else where bilingual clinicians are not readily available and where interpreters are still a common solution. Considerations related to international telepsychiatry are primarily based on licensure and national laws and regulations related to the location of the patient and the professional respectively. According to required licensing laws, it is common that the patient cannot be treated if he or she is not located in the same country as the psychiatrist. Many patients who already see a psychiatrist may be exposed to significant disruption of care in the case of travel, work, or study abroad, as they would either be forced to see another professional licensed in the respective country or not see anyone at all. WPA's global guidelines for telepsychiatry discuss a recent phenomenon called the meeting in the cloud. It is up in the cloud we meet our patients while providing remote internet-based consultations. The location of the cloud is determined by the location of the internet server, not by the physical location of either the doctor or the patient. Conceptualization of the visit up in the cloud then may cause future changes in existing regulations. This momentum poses new challenges for licensing authorities and calls for international cooperation between decision makers related to the remote provision of mental health care in the future. Therefore, we encourage policymakers to start the work of creating uniform licensing rules, first regional and then global. 6 decades of practicing and researching within the field of telepsychiatry have proved that it is comparable to in-person services in terms of reliability of clinical assessment and treatment outcomes. Sometimes we may be even more effective than in person when it comes to remote delivery of services to specific patient populations, such as individuals within autism spectrum, child and adolescent who are used on remote communication and the use of mobile devices, or cross-cultural patient population. There is a strong body of evidence for how telepsychiatry can be used to offer effective care in every psychiatric condition. Today we will mention some. Randomized controlled equivalence trials has been done 15 years ago, confirming the reliability and similar outcomes of telepsychiatry approaches in treatment of depression. Regarding ADHD, it is proved that children and caregivers experience greater improvements in outcomes when receiving telepsychiatry-provided assistance than children and caregivers who received traditional in-person treatment. The applicability of telepsychiatry to the assessment and treatment of patients with schizophrenia has been studied and described ever since the 1990s. High acceptance and reliability have been proven and results published in a number of articles. This only confirms the notion that even seriously ill patients can benefit from telepsychiatry when provided by competent clinicians within standardized service settings. This is important to remember, as we still nowadays may hear that paranoid patients, for example, are not suitable for telepsychiatry. If paranoid patients, as well as any other, get proper and easy to understand information about telepsychiatry, then the risk for paranoid thoughts related to video cameras will be significantly diminished. My first experiences with telepsychiatry go back to the beginning of this century when I installed video equipment at the closed psychiatric ward in Copenhagen. All our patients were within F20 diagnosed spectrum. I saw them via video once a week, while the rest of the week we had the treatment as usual in person. After 6 months, I conducted a satisfaction survey asking for whether the patient was paranoid toward the video camera. The answer I got from majority of the patients was the same. No, I wasn't paranoid because you explained everything to me before we started. But yes, I'm still afraid of those video cameras that I cannot see, but which are hidden. What I learned is that we may not underestimate the importance of detailed information prior to starting the course of telepsychiatry treatment, especially with patients who do not have previous experiences with such services. We may conclude that telepsychiatry leads to better outcomes, improved clinical experience, lower costs, and improved patient experience. But we must not forget that the satisfaction surveys explored the telepsychiatry via standardized standalone video equipment, as at that time we did not have video platforms and software like we have on nowadays sophisticated mobile devices. The question is whether this is the case for home telepsychiatry when delivered via media that limits optimal body language reading. Future research may provide answers to the level of satisfaction of both patients and professionals alike. Although telepsychiatry service is convenient for patients, before the current pandemic, the barriers from a clinician's perspective were most concerning. This is because clinicians serve as gatekeepers for implementation and sustainability of telepsychiatry services. A few of the many barriers identified by clinicians include data safety concerns, reimbursement, quality of practice, lack of experience with the use of technology, and difficulties in changing daily routines. However, current pandemic proved that the adoption of telepsychiatry does not require unprecedented efforts, but primarily the removal of regulatory barriers, which enables better access to care, reduced no-show rates, and increased the level of patient satisfaction. The professionals are able to adjust very quick when the strict regulations are waived. The professionals have also showed ability to change daily routines due to extraordinary circumstances such as COVID-19 pandemic. Recent experiences may pave the way for significant changes in the clinician's daily work when it comes to the use of telepsychiatry in the future.